Hi, I'm Michelle Grazoulis, and I'm president of the foundations at Rochester Regional Health. Thanks for joining us today for this Facebook Live chat, and I'm happy to be joined by Dr. Kelly Matmati, who is the Stroke Program Director at Rochester General Hospital. And for those of you who don't know, May is Stroke Awareness Month. Kelly, thanks for joining us.
Sure.
Happy to have you here. So, as always, I invite you to ask questions. Feel free to write them in, and we'll periodically stop and check to see if there's some questions you'd like answered. So let's jump in and get started. Let's start with the basics for folks who are listening who might not understand. Tell us what a stroke is.
So a stroke is a sudden onset of neurological symptoms caused by a blood flow or blood vessel problem. So what that means is if you suddenly have weakness, numbness on one side, speech changes or vision changes, that's caused by either a blockage in one of the blood vessels that supplies the brain or a rupture of one of those blood vessels.
So when people say I've had a stroke, and the stroke is so we know a stroke is a result of a vessel issue, let's say a clot. Can the clot be in your leg and you still had a stroke, or does that it has to travel to your brain to be considered a stroke? Is that correct?
Right. So
okay.
There's it can originate elsewhere in the body, but it goes to the brain and affects the blood flow to the brain.
Okay. And how many people suffer strokes every year?
So almost 800,000 people in the United States every year suffer from a stroke. And it's also the fifth leading cause of death and one of the leading causes of disability in the United States.
I want to come back to the death and disability piece of it, because I've learned through the years that, stroke is that thing that if you can identify it and get treatment, there's so many ways that it can be treated to prevent the disability component to it, and
right.
Death, obviously.
Yeah, that's true.
So let's talk about signs and symptoms. Tell the listeners, what are some of the signs that you might be having a stroke or symptoms that you need to immediately respond to?
So we use an acronym called FAST to remember some of the common symptoms of stroke. So the F stands for face. If you have a sudden onset of drooping of one side of the face or asymmetry of the face. A stands for arm. So if you have weakness of one arm where you can't hold it up and the arm drifts downward. You can also have weakness in the leg as well.
Is it one side only?
It's usually one side only.
And it would be the same side, leg and arm?
Usually,
okay.
Yeah, it would be the same side that you'd have weakness in a leg and or an arm.
Okay.
S stands for speech. So you can either have slurred speech or difficulty coming up with or articulating the words. And T stands for time, which means time to call 911. Okay. So stroke is an emergency. If you have sudden onset of any of those symptoms, it means it's time to call 911.
Okay. So this may be a silly question, but the drooping of the face, is that something that people, would patients say, I could feel it happening, or is it I'm looking at you and I notice that it's happening? Does that make sense?
So usually they notice it when they look in the mirror,
okay.
Or a family member will notice that something doesn't quite look right in the face.
And it doesn't have to be all three of those things, correct? It could be one?
Correct. It could be one of those things. And there are also other symptoms of stroke that aren't covered by the FAST acronym, such as loss of vision in one eye or on one side of the world. Could also be sudden onset of severe vertigo and balance issues, or other vision problems like double vision.
Yeah. I had a former employee who was telling us she ended up having a stroke, and she was telling us a story of it, and she said what was so striking to her was, and she's a nurse by training, she said, I, in my brain, heard myself saying words, but she was with her daughter, and her daughter said, what was coming out of your mouth made absolutely no sense. Mm-hmm. But yet, she was thinking she was actually making sense. So it's a really interesting. So call 911.
Correct.
And immediately talk to us about the treatment. What should someone do? Call 911, get to the hospital, and then talk to us about what happens.
So if you call 911, and it actually is important to call 911 and not drive yourself or have a family member drive you to the hospital.
I assumed.
And that's because the EMS personnel will call ahead to a primary stroke center. A primary stroke center is a hospital that has been certified to treat strokes. And they will be ready for you when you arrive. Yeah. And they'll take you straight to the CAT scan, get a CAT scan of your head, make sure that there's no bleeding in the brain. And then if you're within a certain time window, they may be able to give you a medication to treat stroke. There's a medication called TPA that is a clot-busting medication that can dissolve the clot that's causing the stroke if you meet certain criteria.
And that's I say relatively new as in the last, 10 years?
Maybe 15 years by now.
Okay.
Yeah.
But that's the primary first treatment, correct?
So
'Cause
that
you hear so
is-
much about TPA.
Right. So TPA is the primary treatment for patients that come to the hospital within 4.5 hours of the last time they were known well. There is also a newer treatment available for certain types of stroke. For strokes that are caused by a blockage of a large vessel in the brain,
Okay.
there's a treatment called endovascular therapy, in which they can go in with a catheter into the large vessel and try to pull the clot out and stop the stroke.
Okay. So we talked a little bit about signs and symptoms. Let's talk about risk factors. So share with the listeners, what are some of the risk factors for stroke, and is there a genetic predisposition for it? What are things that people should know to pay attention to?
So one of the main risk factors for stroke is high blood pressure. I would say that is far and above the most significant and common risk factor. So high blood pressure that's not controlled by medications over a long period of time puts you at risk for stroke. Also, diabetes is a risk factor, particularly if it's not well controlled. Smoking is a very big risk factor for stroke. And then there's other things like family history puts you at risk of stroke, and certain heart conditions, or such as atrial fibrillation, which is an abnormal heart rhythm.
Okay. And so the I guess the guidance you would provide there would be talk to your physician about your family history and
go to your primary doctor.
That's a good place to start.
And make sure that they're screening you for things like high blood pressure and diabetes and high cholesterol. And if you have those things, make sure that you're taking the medications and keeping those things under control.
Yeah. I'm going to pause and reintroduce you and see if there's any questions. So I'm joined today by Dr. Kelly Matmati, who is the Stroke Program Director at Rochester General Hospital. It is Stroke Awareness Month, and we're happy to have Dr. Matmati with us. Thanks for joining us. Phil, any questions?
It seems like there's more and more people who are younger having strokes. Is there any reasoning, overarching reason that we're seeing younger people suffering strokes?
So that's true. There are more people, under the age of say 60 that are having strokes, and I'd put them in two categories. One is that we're seeing more of the traditional risk factors that people tend to get as they age are occurring younger and younger.
Obesity.
So things like high blood pressure and diabetes are occurring younger, as well as obesity.
Yeah, which is causing the other two.
Right.
Yeah.
And an unhealthy lifestyle.
Yeah.
And smoking. The other category of young strokes are the more rare conditions that we see, such as certain genetic conditions or inflammatory conditions, or even patent foramen ovale, which is a type of hole in the heart.
Okay. So I want to jump to and talk a little bit about Rochester Regional Health and our approach to neurology and stroke care, because I'm confident that you're extremely proud of it, but I'm as well from the foundation side, because I think that we do an exceptional job of providing an incredible footprint for stroke care and neurological care. So talk a little bit about our approach holistically as a health system, if you could.
Sure, I'm glad you asked, because I have a lot to say about that topic.
Good.
So Rochester Regional Health has several primary stroke centers, as well as at Rochester General, we have a higher level stroke center that's able to give higher level stroke treatments. So what that means is that if someone presents with stroke symptoms anywhere in our community, they can be taken to one of the stroke centers where they can receive TPA and get good acute stroke care. If they have signs or symptoms of a large vessel stroke, like I was talking about earlier, they can be transported to Rochester General, where we have endovascular therapy. We have physicians who can go in with a catheter and try to pull the clot out, which is a higher level of acute stroke care. We also have stroke units in each of the primary stroke centers. And at Rochester Regional, we have neurocritical care within the surgical ICU at Rochester General that can provide higher level stroke care for the sicker patients with larger strokes.
So when you say the stroke centers, you're talking about Unity, right? RGH, Newark, Clifton, and UMMC are sort of not strokes, not.
So Newark, Wayne is a primary stroke center certified by the state of New York, and as well as UMMC.
Okay.
Clifton Springs is not; it's more of a critical access hospital, but we do get calls from them as well.
Yeah, and I find that to be really interesting when I'm out talking with folks in the community about our ability to reach the full geography that we support. Telemedicine in neurology in particular and in strokes has provided an opportunity for patients in, say, the eastern region or our western region to communicate with physicians immediately at RGH or Unity.
Right. So we have a new telestroke telemedicine program in which patients that present to any of the hospitals in the system we can actually, the neurologists at Rochester General, we can connect with them through a live video connection and examine the patient through the video link and talk to the ED physician and get the full history and help them decide about acute stroke treatment, whether that patient needs TPA, whether they need to be transferred for a higher level of care. So I think that's really enhanced our ability to provide high-level stroke care throughout the system.
I think it's amazing. So why did you become a doctor?
Well, I started my career in science. I was a researcher in biology, and I enjoyed that, but I really missed, knowing what happens to the patients. So we're doing all of this research on neurologic conditions, but I never got to meet a patient who had any of those conditions, and I never got to see how they might be helped by the research. So I really wanted to have more of a face-to-face connection with the patients and be able to really see, be able to help somebody who's right in front of me.
Why neurology? Why strokes? What's it about that interested you?
Well, I think neurology is probably the most fascinating area in medicine because it deals with the brain, which is just a very interesting subject. And stroke is exciting because it happens so quickly. Yeah. And now we have these acute treatments that we can do to actually help people. In the past, when someone would come in with a stroke, it was just, kind of wait, there's nothing we can do for you. Yeah. We'll just, let you stay here in the hospital. Yeah. But now there's really a lot that we can do for stroke patients to limit the stroke and limit their disability. So it's an exciting time in stroke care.
Yeah. And I think it's really just to go back to our footprint from a Rochester Regional Health perspective. I mean, I think the other thing that we do an exceptional job of is providing resources and support and rehab treatment for patients that have suffered either traumatic brain injuries or stroke through the Golisano Neuro Rehab Center at Unity. So it's just a great footprint for us as a health system. So let's talk about resources. So if someone is listening and says, I want to learn more, what would you suggest they go and do?
So a really great resource is the American Heart Association and Stroke Association. Their website is strokeassociation.org. So there's a lot of really great educational materials about stroke. Okay. We also have within our system, we have 2 stroke support groups. So anyone who's suffered a stroke is welcome to come and join our stroke support groups.
How would someone get connected to those?
You could call the neurology office, which I think we can leave that number in the comment section afterward, and they can give you information on when those take place. We have one located over at Unity, and we have one located at the RGH campus.
Okay.
Also, if we have a stroke and TIA clinic, and we see all of our patients in follow-up after discharge from the hospital.
Tell the audience what TIA is.
So TIA is transient ischemic attack, and basically a TIA is just like a stroke, except that the symptoms get better and there's no permanent damage. Okay. But we really consider it a warning sign for a stroke, and we treat it with the same urgency as a stroke. Okay. So we have a stroke and TIA clinic in which we see all of our stroke patients and TIA patients within 1 to 2 weeks after they leave the hospital. But we also accept referrals from primary care physicians for patients that need follow-up after a stroke or need some further care. So
I'm interested to understand what you tell patients. So you see patients who have had a stroke, and you're trying to either help them recover from that and carry on the lives that they had before. So what's the most important advice that you would give to your patients? What do you try to either inspire them or encourage them to do that's going to help them feel better or live a longer life.
So as far as patients who have had strokes and who are in the recovery
because that's who
phase?
you see predominantly, right? Yeah, you see them after they've had a stroke versus on the primary care side, I guess.
Right.
I'm getting at.
And I would say in the early period after a stroke, I really focus on trying to give people hope because a stroke, typically patients don't die from strokes. And there is quite a bit of hope for recovery. When they first come into the hospital, it can seem very discouraging when they have, profound weakness or speech difficulty. But the brain is very flexible, and the brain wants to recover. And I just tell people things are going to get better. Just give it time. Work hard in rehab, and things are going to improve for you.
I think hope is good. I think hope is good. So before we wrap it up, Phil, any questions?
Yeah, talk about the Golisano Restorative Neurology, the rehab center that we have, and what patients have available to them there, and the resource that it is.
So going back to the full continuum of stroke care that we were talking about earlier, after a patient has been treated in the hospital for a stroke, oftentimes they'll need a period of rehabilitation to be able to go back to living independently at home. So there's two levels of rehabilitation. There's acute rehab, which our acute rehab in the system is the Golisano rehab over at Unity. And there's also what we call subacute rehab, which is we have other facilities in the system that do subacute rehab, which is a little bit less intense form of rehab. The Golisano Rehab Center is
It's
really,
amazing.
it's really, I don't know if you've seen it, but
Oh my God, I spent plenty of time over there. Yeah, I think it's amazing.
we're really lucky to have that in the system, and we're able to send our patients who need acute rehab over there to get rehab, and everyone all of our patients are very happy with the care that they receive there, and we see a lot of amazing recoveries come out of there.
It's for PT, OT, speech therapy, does all of that as well as coordinate. I mean, it's
Right.
really comprehensive in terms of the level of rehabilitation support that we offer or provide. So it's pretty amazing.
And then you touched on time, but can you talk about just some of the statistics of how soon TPA needs to be administered and how soon you should be seen? Because a lot of people seem to brush off a stroke or the symptoms that they're feeling.
Like a heart attack. You don't think it is what it is.
So if you notice any signs or symptoms of stroke, don't take a nap. Don't go to bed and assume it's going to go away. You need to call 911 and get in immediately. For most patients, we can give TPA up to 4.5 hours from last known well. Some patients...
What does that mean, last known well?
So the last time they are sure or someone saw them at their baseline.
Okay.
Because sometimes they're not able to tell us when the symptoms started.
Okay.
Or for example, if you woke up from a nap and you had these symptoms, we would go by the time that you went to sleep.
Okay.
So we can give TPA up to 4.5 hours, and in some patients it's up to 3 hours, depending on other factors.
And the time frame that, the 3 hours or 4.5 hours, administering it after that, it's just not effective, or help me understand, you just can't do it, or what's the impact of doing it after that time frame?
So since TPA is a clot busting drug, the major risk is bleeding, and that includes bleeding into the brain.
Okay.
And the longer you wait after a stroke, the higher to give this medication, the higher risk of bleeding. And so they found that sometime at around that 4.5 hour window is when the benefits seem to be outweighed by the risks of bleeding.
That makes sense. Got it. Phil, any other questions? We're good? So, in conclusion, first of all, thank you for being here and educating me and everybody else on stroke and stroke awareness. Any final thoughts, things that you would want to share with the audience based on what we're doing or what's exciting happening at Rochester Regional Health?
Well, I did want to talk a little bit more about the continuum of stroke care. So in addition to what I've already told you, we have we call it our Stroke Navigator program. So patients that present to either Unity Hospital or RGH will be met by our stroke nurse navigators and educated about stroke. And they also call them and follow up after discharge and make sure that they understand all of their medications and answer any questions they have. And then when the patients come back to clinic within 1 to 2 weeks, they meet them there. They already know each other, and again reinforce that education. So we have the navigators really help guide our patients through the continuum of care.
And probably, I would think, I'm sure that that's probably a result of some kind of a pilot program that shows greater compliance with medication and follow-up, if you have somebody helping to navigate.
Right, and we received a grant from the Greater Rochester Health Foundation for that.
Yeah.
Yeah.
I thought it was potentially that grant. And I think it's really important. We're finding in lots of our service lines that if you have someone in that navigator role helping, you find it just makes it easier for the patient, and it's less intimidating as well. And then ultimately we have greater compliance, which is what we want.
And stroke patients, sometimes have difficulty, remembering what medications they're supposed to be taking. The stroke is, has had an impact, and they sometimes need some help or need reminders in remembering to take their medications, remembering to come to their follow-up appointments, being able to arrange transportation for follow-ups and things like that.
So it sounds like overall we're doing a great job in neurosciences at Rochester Regional Health. I sort of say that tongue-in-cheek because I'm incredibly proud of what we're doing. And I appreciate you sharing your perspective with us and educating the audience. So unless there's any additional questions, thank you so much, Dr. Matmati, for spending time with me. Have a great weekend, everybody. Thank you very much.